Okay.
Okay, this is part of Dr. Ikmal attachments program that he has to present, and this is actually the third presentation. We did two last week. Yep.
Yep.
Okay, Dr. Ikmal.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So our topic today regarding the fourth series of the pursuing perfection in intraocular lens calculation. Actually, there are four papers, but I just jumped to the last one. Okay, the first one actually regarding the approach how to reclassify the IUL formula to make it more accurate. And then the second paper, what are the measurements error that occur preoperatively that can affect the quality outcome of the surgery. And then the third one, the parameters and criteria to analyze the outcome. Now we go to the fourth paper about the astigmatism analysis, how to perform the astigmatism analysis. This is a challenging topic because analyzing astigmatism change following IUL-based surgery is more difficult compared to the corneal-based surgery. Yeah, because the first thing why it is difficult because there are range of analytical approach, Alpin's method, power vector analysis, multiple methods that the scientists already come out for the analysis. And in corneal refractive surgery, the parameters that we will use is only refraction and anterior corneal curvature. However, in IUL based surgery, multiple parameters that's required to analyze the astigmatic changes, refraction, anterior corneal curvature, posterior corneal curvature, IUL alignment, effective IUL toricity at corneal plane, IUL tilt. So multiple parameters that we need to analyze. So how actually the cataract surgery alter the ocular astigmatism? So first one is non-toric IOL without LRI can cause ocular astigmatism. Non-toric IOL with LRI also leads to the changes in corneal ocular astigmatism. Toric IOL without LRI, toric IOL with limbal relaxing incision. So before we go further, we need to know certain terminology. Predicted SIA, surgical induced astigmatism, means that the astigmatic changes that surgery was designed to produce, what we aim for actually. And then the actual SIA is the astigmatic changes that the surgery produced post-operatively. And SIA prediction error is the vector difference between the actual SIA with the predicted SIA. So we can further classify the SIA into three groups, SIA cornea, SIA IOL, and SIA total. So SIA cornea is affected by the cataract incision, and maybe there is additional incision such as a limbal relaxing incision. And while the SIA-IOL is affected by the IOL toricity, or maybe the non-toric IOL, but because affected by the IOL tip or IOL decentration. So SIA total is the total astigmatic changes induced by the surgery. Further terminology, predicted post-op refractive astigmatism means that our predicted post-op refractive astigmatism at corneal plane. Actual post-op refractive astigmatism is the post-op manifest refractive astigmatism at corneal plane post-operatively. Post-op refractive astigmatism prediction error is the vector difference between the actual and predicted post-op refractive astigmatism. So we go further, we discuss regarding the SIA cornea. Okay, SIA cornea is the astigmatic changes by the surgical incision and the relaxing incision. So post-op measurement of corneal astigmatism will analyze the outcome of the toric IOL surgery. So traditionally, actually, in SIA cornea, the mean vector, they analyze with the mean vector magnitude, but ignoring the vector angle. So that's the issue, ignoring the vector angle. So what this paper proposed is we use the centroid analysis, which incorporate both magnitude as well as the meridian. As we know, there is magnitude and meridian. So for the centroid, it analyzed both. So it's not, but this cornea SIE is very complex because there is case-to-case variability, as we know. The biomechanical property of the cornea is different person to person. Character cornea is also different biomechanical property. So that's the complexity. The second one, the accuracy of cornea astigmatism measurement, because although we have all the technology now, but with the OCT and all the corneal topography, but there is still, from this paper said that there is still no validated method to measure the total corneal astigmatism. And relatively low repeatability of the measurements there, because there is one study here for the 27 participant for the normal eyes. Okay, the same eye taken the measurement of the corneal curvature of the astigmatism of 1 day and 5 to 10 days apart. So it shows that the reading shows apart, okay, difference largely from the first day and the second day. So means that there is low repeatability of the measurement by the machines for the topographer, Shim-Flach. Okay, this one is for the topographer, and the second one is from the Shim-Flach machine. And then the fourth challenges is the stability of the actual SIA cornea over time. Means that post-op 1 month maybe different diopter astigmatism, and then post-op 3 months become changes of the cornea astigmatism. So the second SIA is SIA intraocular lens. Astigmatism induced, what is the definition of SIA-IOL? Is the astigmatism induced by the toric IOL at the corneal plane. So SIA-IOL prediction error is caused by the incorrect estimation of the effective cylinder power of the toric IOL, or toric IOL misalignment, or there is a difference in actual versus label IOL spherical and toric power. There is difference. And IOL tip or decentration. So further, what is the issue with the toric IOL calculator? The previous one actually. So previously, the toric calculator use only fixed ratio between the IOL power and cornea astigmatism, and ignoring other variables, and ignoring the predicted ELP, effective lens position, and also spherical equivalent power of the IOL. Also ignoring the post-corneal astigmatism. Okay, that's why we can divide the toric IOL calculator into three type of formula. The first one is the PCA fixed ratio calculation, which is the older one. The ELP based formula, and then the third one is the PCA and ELP based formula. So what's the difference? In fixed ratio calculation does not predict the posterior corneal astigmatism and assume fixed ratio of the IOL to the corneal plane. However, in the ELP based formula, it includes the ELP, one of the parameters. All right, so and the PCA and ELP based formula, it includes the PCA, posterior corneal astigmatism, okay, such as in the Abul Afia Koch regression formula, as well as the Barrett's toric formula. All right, so SIA total. What is SIA total? SIA total is a predicted SIA total with a predicted SIA cornea plus predicted SIA, IOL. So ideally, for the actual surgical index astigmatism total, which is the actual SIA cornea plus actual SIA IOL. However, usually, what we calculate for the actual SIA total is the difference between the actual post-op refractive astigmatism and pre-op corneal astigmatism. So, how to do the analysis? The suggestion of this paper, we do analysis using single or double angle plot. Which one we want to use? Okay, so as we said earlier that we need to change from the mean magnitude analysis into the vector analysis, because the vector analysis include the magnitude as well as the meridian of the changes. Okay, in the left hand side here is the single angle plot, and the right hand side here is double angle plot. The authors suggest we use the double angle plot because we can see here, okay, if with the root astigmatism, the single angle plot is within one group. However, for the analysis of the against the root astigmatism, the analysis is separated into two groups. So the analysis may be not very accurate compared to the double angle plot. The withdrawal astigmatism is analyzed within one group, and against the root astigmatism is analyzed within one group here. All right. And then yeah, so for example, if there is astigmatism value of 1 diopter at, such as here at the 1 degree, and there is another 1 diopter at the 179 degree here. So there is 1 diopteric difference between these 2 points. However, if we put 1 diopter here at 1 degree here for the against the root astigmatism, and 1 diopter at the 179, okay, we maintain this partial relationship. So it's just near and at one group, near to each other. So the analysis is more accurate for the double angle plot. Okay, this is the example for the single angle plot analysis. Okay, if we can separate the data into the against the rule, with the rule astigmatism or oblique astigmatism, we can see here the with the rule astigmatism is grouped together, and we can see the vector mean here at the center. However, for the against the rule astigmatism, the analysis, the group is separated into two polar here, and then and as well as the oblique astigmatism. So the analysis is not very accurate compared to the double angle plot here. So all the data is have centroid, the central mean. So the centroid is the mean magnitude as well as the meridian. So this is the number, okay, 0.02 diopter at 24 centroid, one figure only. And then the centroid is surrounded by the 95% confidence elite data set. So 95% confidence interval lah, that's our analysis in the in any other analysis. All right. So more accurate. So how to reporting the outcome? So firstly, we need to ask ourselves how much astigmatism was present before and after toric iron implantation. Okay, we can present the data as the bar chart here, pre-operative and post-operative. Okay, mean. Okay, all right. So this is the simple one, basic one. And then further, we need to ask what are the pre-operative and post-operative astigmatic vectors and their mean and spread. So we can present the double angle plot into pre-operative corneal astigmatism and post-operative astigmatism. So we can see here, okay, pre-operatively the centroid And also there is 95% confidence ellipse of the centroid, as well as there is 95%, the blue one, 95% confidence ellipse of the data set. And we can see here post-operatively the the confidence interval become smaller, means that become more precise. All right. So we analyze pre-operative and post-operative astigmatism. So how can we know how accurate were the toric IUL calculation formula? How can we calculate post-operatively how we do the analysis? So this is the most important graph for us to analyze our own post-op toric IUL uh, post-op estimate analysis. So post-op refractive estimation prediction error. So we need to calculate the prediction error and put in the analysis. So such as in this picture, the centroid is decentered a bit, and then this is the 95% confidence interval. So in this analysis for this data set, so the centroid is 0.55 diopter at 180 degree. And we also can separate the table into 25 less than 25 degree, less than 50 sorry, less than 25 diopter, less than 50 diopter, less than 75 diopter, and less than 1 diopter. We can know how accurate our post-op prediction, how accurate our post-op prediction. All right, by knowing the post-op by knowing the prediction error. Okay. This one actually the post-op refractive astigmatism prediction error, but the adjusted with the Abul Afia Koch formula. So how actually to use this one, this analysis, we can go to the website, SIA calculator website, which is developed by the Warren Hill, Dr. Warren Hill. And we can put the parameters and data, our data in the online calculator, and we can get the double angle plot analysis to check for our accuracy of our surgery. So in conclusion, we already covered the important terminologies in cataract surgery. The second one, the SIA and post-op refractive astigmatism, and toric IUL calculation, which is then the fourth one is double angle plot and how to report the outcome. Thank you.
Okay, thank you so much, Dr. Ikmal. Can we go back to the your presentation? I just pick one. Again, okay, just stay there. So if you look at this, why this is actually used in our training, because it give an overview about just looking at astigmatism. Of course, there's actually a lot to discuss in each of the component. But just to show you how basically, when we approach to certain things in terms of getting the predicted outcome, what we want to know or what we want to aim for, and how do we actually improve on that, and we need the basis of all this particular knowledge. Now it can be like for certain people it is a bit going to the academia, when it's on academic. But if you look at it, this is how, if people are serious about lens refractive surgery, this is how they actually try to understand what's going on. And even as a clinician who actually look into this, they be able to actually appreciate that, okay, now when we talk about astigmatism is totally different uh, when we want to improve it compared to the overall outcome. So that's very important to start with. The second one, especially for those who actually coming for the attachment and part of our program, members of our program, you can hear this all the time. I think this must be at least the 6 to 7 presentation that we had, because that is actually how many people have actually attached to us for 2 weeks attachment. But if you look at it, it doesn't fix into your routine if you don't do it. And the challenge is not now, especially currently, is not just knowing it, but how do you actually execute it? And that is become problematic. And usually if you come, for example, if let's say you're in actually a long program like Dr. Aimi, so what we're going to do is when you look into this, you will divide them into a few components for you to, for you to start and look at whether you can improve this. The first one is actually, what we do is actually knowledge based. You actually look into that knowledge, or this need to be done. This need to be done because you need to quantify. After that knowledge base, now you go to the executions of it, how to quantify, because quantification basically looking at what are the current results that you have, and that's why we look into the total refractive astigmatism and the cornea astigmatism, because this is the two particular results. It is easy for you to quantify, and once we have that, then only that you can rectify. Yeah. So from knowledge, quantify, and rectification, and that need the process for each individual surgeon or each individual particular center. And it's not easy because once you want to quantify, even at the level of quantification, you do need help from your staff. And then a very difficult for you to do it consistently. And the reason I know this because we are struggling with that as well. The only when you actually have that, quantify what's going on, and by rights, that should be done at least every 6 monthly, if not yearly. So you need to actually have that quantification for both actually the corneal astig as well as the total refractive astig. Then after that you can rectify. So you can see that it's not easy because to quantify, as what Ikmal presented, there is you need to know about how to quantify them appropriately, and that's why we go to the issue with centroid. And as I said, with the now becoming better, because once it is actually better, the reason why it's better because we have a lot of tools. But again, the process of quantification is retrieving the charts, making sure that the K was taken post-op, and then looking at what's going on. So it is not easy in terms of executing it. But if you don't execute it, then that's why what happened with all our surgical outcome. We are unable to actually identify them, quantify them to actually rectify the problem. Um, okay, Ikmal, how do you feel when you actually review the paper, Ikmal? Among the four, this is actually the one of the, I think the toughest in terms of to review it because so many terminology.
Yeah, actually, we first proceed, we need to start to execute what we have learned. We need to do the proper analysis to get our SIA from. And then
Yep.
yeah, to look for our double angle plot maybe every 3 months, okay, to and then we need to, if the double angle plot, the vector and 95% confidence interval is too large, then we need to check again the preoperative measurements, how do measurements, how we do the which IUL which the calculator that we use. So we need to refine again everything until we finally we get this centroid with the 95% confidence ellipse small. Yeah, that's my
Mm.
take on it.
So, yep. So, we always move forward in terms of redesigning our courses, and just to inform Shafi. So the next INOBC is actually we're going to have a session just to address all this and with practical, with hands-on practical. We did the INOBC before where we actually spread the table of or the position of each of the candidate, and the reason why we do that because the next step is, can we actually have laptop in each one of the table and then going through all this. So it's going to be it's going to be looking at this. So it's easy to know, but now when you actually want to do it, we do need to have a specific workshop or course to do that. So this is what's actually behind what I planned before, saying that we need to start to talk about it. But for specific people who wants to know and to go through, we will go through this with the example. And with that example, that's why we're going to prepare for the next course. There already a spreadsheet. In that spreadsheet, that we give the sample of data, and then the candidate actually put it in. With that, they actually look at what's going. So it has to be to that level to make sure that people understand what's going on, because we've done this. I mean, I've done this training like few years already. I know the problem with that is actually it is not like directed. So that's why I say each year IONBC will be different, each year will be different, but the next year, this is what we are targeting. Meaning that if you come, we just look into that, look at how you actually develop that double angle plot, and how do you actually do that reporting outcome. That alone will take, I think, at least the whole morning. But it's good to do that, so we're more directed, rather than it's just talking about, we did a good one last I think last 2 weeks, or last 3 weeks, that we actually look at each component, the formula, the exit length, as well as the key issue. But now we actually, the INOVC have to move on and looking at how do we perform this. As a surgeon who are coming in, they need to be trained to do that. Yeah. So I think Dr. Shaf will take note of this. And thank you, Ikmal, for that presentation. I think we go to the second part of presentation. Dr. Hadi, for your CA. Is that correct?
Yeah, Prof.
Okay, so we're going to actually, yep, Dr. Ikmal can share, and we let Dr. Hadi to share. Thank you.
Okay, Bismillahirrahmanirrahim. Okay, Assalamualaikum warahmatullahi wabarakatuh, and very good morning to everyone. So for the morning critical present today, I'm going to represent this topic. This topic I had presented about 5 months ago, but I chose this topic, okay, maybe because of few cases that we encountered recently in these few weeks during our clinic. All right, so the topic of my presentation today will be the incidence and risk factors for retinal detachment and retinal tear after cataract surgery. Okay, so this is the first page. It was published in Ophthalmology in April 2023. All right, so again, why this study was chosen? So we know that the retinal detachment after cataract surgery, okay, also what we call the pseudophakic RRD. It was an uncommon complication, but it is an highly potential cause of reduced vision to the patients. All right. For the purpose of the discussion today, I just brought it again, that example that I presented before, where we had two patients that we encounter in our clinic. Okay, they had the pseudophakic RD. So this patient, the first patient, 50 years old male, he had right eye dense white cataract with high myopia. The cataract surgery was complicated with PC ran and vitreous loss. So we did phaco, intravitreal, ACIOL, and PI for him. But unfortunately, he developed retinal tear with superior bullous RRD 2 months post-operative. So we did the TPPV for this patient. But again, it's about 3 months. It's about almost around 6 months post TPP currently. Again, because of the nature of patient, he had high myopia with the long eyeball. All right, he had complicated phaco before. So again, the the TPP was successful, but again, when we talk about the vision, the best vision we can get from him is about 660, because he developed the macula hole post TPPV. It's about 6 months currently. Okay, then we had another patient. Okay, this patient, he's a 60 years old male. Also, he had right eye dense cataract. However, he underwent uncomplicated cataract surgery, but he developed retinal tear with subtotal bullous RRD. It's about 2 weeks post-operatively. All right. So looking at these two cases, both cases has different profile. One with the both had dense white cataract, but the one had complicated surgery, and the other one had uncomplicated surgery. But both end up with the pseudophakic bullous RRD. And also, again, another example we had encountered recently in our clinic. We had patients developed pseudophakic RRD. He initially was referred to us because of the subluxated IOL, in which we operated him. We did the PPV with ACLL. Alhamdulillah, he had good vision post-operatively, but about 1 month post-operatively, again, he experienced drop of vision. Then we found out he had inferior RRD post TPPV for the subluxated IOL. And all right, so I think it's a good time for us to go through again what are the incidence of the pseudophakic RRD and retinal tear, what are the risk factors that associated with it. Then this information will help us, especially during the pre-operative counseling to the patients. All right. So okay, so the general review questions is we want to look at the incidence rate of RRD and retinal tear without RRD within 1 year after cataract surgery, and what are the risk factors for the retinal event post cataract surgery. Again, as I said before, the cataract surgery is one of the most commonly performed surgery worldwide. In the USA, it's about more than 2 million cases performed annually. All right. Then the RRD and retinal tear with the RRD, even though it is uncommon post cataract surgery, but it has high potential to result in vision disturbance to this patient. Then from the previous literature, they studied about the incidence of RRD. They found that 10 years incidence of RD post-cataract surgery, it ranged between 0.36% and 2.9%. Okay, the methods of the study, this is a retrospective analysis of medical records. It involved the 3,177,195 eyes from the IRIS registry, the duration between 2014 to 2017. So what is IRIS? All right, IRIS registry stands for Intelligent Research Insight Registry. It's a large national registry containing more than 70 million patients' records. So the IRIS registry, it contains data sets of unique randomly generated identifier for patients mapped to demographic features, the structured diagnosis, and the procedure codes, as well as the clinical observation. All right, for the patient population, the inclusion criteria would be all patients eye that receiving cataract surgery from 2014 to 2017, and the exclusion criteria, the patient age less than 40 years old, history of diabetic retinopathy, history of RRD or retinal tear, the outcome event that occur after 1 year excluded, then the follow-up visit less than 1 year. All right. In the IRIS system, all right, the number of cataract surgery record from 2014 to 2017 was 7,598,783 eyes. Okay. To be included in this study, the determination of procedure laterality was required. So, okay, hold on. Okay, so any patients that had issue with the laterality, okay, maybe due to improper documentation in the system, so they will be included. So from the 7,598,783 eyes, it comes down to 7,852 and 781 eyes. Then from this number, the case excluded according to the exclusion criteria, so it leave 3,177,195 eyes for the analysis. All right, for the outcome variable, so this study was meant to study the incidence rate of RRD within 1 year of cataract surgery, as well as the incidence rate of retina tear with the RRD within 1 year of cataract surgery. This analysis also was meant to look at the patient's characteristic who are at the risk of developing RRD as well as the retina tear. So they look at the demographic features, the ophthalmic comorbidities. They include the risk factor of the PVD, lattice degeneration, and high myopia, as well as the cataract complexity, including the hypermature cataract, pseudo-exfoliation, floppy iris syndrome, and the use of complex cataract surgery. The use of complex cataract surgery means any complication occur intraoperatively. What are the extra procedure was done intraoperatively? Then for the statistical analysis, they use the Casco test to assess the association between demographic data with RRD and retina tear with the RRD. And they use the single and multiple linear regression to estimate the ratio for each demographic data, the ocular comorbidities, as well as the intraoperative factors. So let's proceed with the result of the study. Okay, this busy table, okay, it's showing this demographic characteristic and its association with the risk of the RRD and retina tear without RRD. So let's go through one by one. First, the incidence rate of RRD and retina tears without RRD. This analysis, they found that from 3,177,195 eyes, from that total patients, 6,690 eyes develop RRD. So it comprises about 0.21%.
Sorry,
Okay,
Usop punya tadi, dia on. Okay, thank you.
Okay, all right. Then for the retina test, total eyes developed retina test without RD, 5,489 eyes. So it comprises about 0.17%. Okay, for the age group, the 1 year incidence for RRD, they found that it was higher in younger age group compared to the older adults. Okay, they classified the patient based on age group 40 to 50, 51 to 60, 61 to 70, and more than 70. So from this analysis, they found that the younger age group, okay, tend to develop RRD and retina test compared to the age group more than 70 years old. And the statistical analysis found that the association was significant. All right. Okay, next, for the gender, the incidence for RRD and retina test was higher in men group. All right. So they compare between men and women. The men's about 0.27% this incidence rate, compared to women 0.11%. Then also for the retina tear, the men also had a higher risk to develop retina tear, 0.24 for men and women 0.13. And also this association was significant. And lastly, for the race and ethnicity, they found that the incidence to develop RRD as well as retina tear was higher in white race and non-Hispanic. And also this association was significant. All right. Okay, so in terms of the timing of event of RRD and retina tear, the timing was about similar. For the RRD, the median of 139 days, and for the retina test is the median of 142 days. And the overall, the majority of RRD and retina tear, it occurs 6 months post cataract surgery. All right. So looking at this statistic, that's why it's important for any patient post cataract surgery. We need to, give them, we need to follow up them. Okay. At least usually we take about the 1 year, because we want to monitor any progression of the things like this. All right. So especially in patient who had the risk factor, so we have to watch out this condition during the review post of 1 month, 3 months, 6 months, and 1 year. Example, all right. Then for the risk factor for the RRD and retina test, the multivariate regression analysis, okay, they reveal increased risk of RRD. Okay, again, the highest, the risk factor to develop RRD, the younger age group, but when they compare between 40 to 50, 51 to 60, and 61 to 70, the age group of 40 to 50 has the highest odds ratio for RRD. But for the retina tear, the highest odds ratio will be in the group of 51 to 60 years old. But whatever is this, still the younger age group, when they compare to more elderly age group, which is the more than 70 years old, the younger age group, they have high risk for RRD and retina tear. Okay, for the gender, again, the analysis, the multivariate regression analysis should increase risk of RRD in men compared to women for both RRD and retina tests. Then for the race, okay, the multivariate analysis showed that the decreased risk of RD and retina tests in Asian race and black race when they compare to white race. All right. Then for the ocular comorbidity, the multivariate analysis, it showed increased risk of RRD in lattice degeneration, high myopia, and patient who had PVD post-operatively. With the lattice degeneration has the highest odds ratio compared to other risk factors. But for the retina test, only the patient who had lattice degeneration showed increased risk to develop retina tear post-operatively. Okay, for the cataracts complexity, the analysis showed only hypermature cataract associated with increase for incidence of RRD, okay, with the significant statistical analysis, but non risk factor was found to be significant in retina test. Then for the use of the complex cataract surgery means any complication occur intraoperatively that required extra procedures. Also, they found the significant increased risk for RRD, okay, but none in retina test. Okay, for the discussion, okay, this study found that the incidence rate for RRD and retina tear post-cataract surgery is about 0.1% for RRD and 0.17% for retina test. From the previous study, the incidence rate of RRD after cataract surgery before the modern day of the small incision cataract surgery, it will range between 0.6 to 1.7%. But more subsequent study, it showed a declining trend of incidence rate. And this study finding also was in line with the declining incidence rate noted in the recent study. About the risk for RRD and retina test, the study found that the major graphic risk factor for RRD after surgery was male group, younger age group, and the white race in because they did in the US, right? Then for the ocular comorbidity and cataract complexity, the risks include the lattice degeneration, high myopia, PVD, hypermetric cataract, and the presence of the complex cataract surgery. I mean, the presence of the intraoperative complication and the need use of the extra procedures during the surgery. All right. Regarding the cause of higher RD risk in younger and male patients, this study, it mentioned that it remains speculative, but they postulate that it may be associated with a higher likelihood of ocular trauma in men, basically. Then for the ocular comorbidity, the lattice degeneration appears to have highest odds ratio for RD and retinal tear, followed by high myopia. So for this group of patients, okay, the patient who had lattice degeneration and high myopia, okay, we really have to counsel them regarding risk of RRD and retinal tear post-operatively. All right. Then other than that, this study also, they suggest for further study on prophylactic treatment such as barricade laser for patients in lattice degeneration, in case it may alter the risk to develop RRD or test after the cataract surgery. Okay, then the things like the hypermetric cataract in intraoperative complications such as PCRAN, they are widely accepted as the major cause of RRD, perhaps due to presence of the retraction in PCRAN and maybe more power or manipulation in case of the hypermetric cataract. Then from this study, interestingly, they found that other risks such as pseudoexfoliation, the floppy iris syndrome did not seem to increase the risk of RRD. They postulated that this may be attributed to the improved knowledge as well as the tools for addressing surgical complexity. All right. So as the conclusion, the overall risk of RRD and retinal tear within 1 year is about 0.1% and 0.17%. So from this analysis, so what we can say is the patient with the risk factors. All right. We need to do careful monitoring post-operatively, okay, especially maybe the one with the risk factors such as lattice, high myopia, or patient who had previously done with the mature cataract, dense cataract, or patient with the intraoperative complications. All right. So knowing the incidence rates and risk factors, so basically useful to guide us in giving the pre-operative counseling. Okay, so we need to inform the patient about the risk and retinal complications. I think if I encounter patient with like high myopia, okay, so I always or patient with the risk factors such as dense cataract, high myopia. All right, you can see me. I just take example of me. I take quite sometimes to give the pre-operative counseling just to inform patient about the possible risk factor that can occur. All right. So patient more understand that their eyes, what we can say, a bit special compared to other patients. So that's why they really need to understand about the risk factor, risk of developing pseudophakic RRD or retinal tear later. Also, we have to inform the patient about this risk so that they understand better. All right. So I think would be my last slide. So thank you for your attention.
Okay, thank you so much, Z. Can we go back to that ni that last slide? The conclusion. Okay. So basically, um, so let's say the statement number one, the overall RRD risk post-op within 1 year is about 0.2.
Yeah, Prof.
0.2 means that 2 in 1,000.
Mm-mm.
2 in 1,000. So that is almost like the average incidence of endophthalmitis.
Yeah,
So
endophthalmitis in post VR basically.
yeah, so so meaning that the take home message for I think everybody for them to understand. So if we counsel patient regarding the possible outcome, for example, like post-op endophthalmitis, we'll see that about two in rarely happen, but the current the current evidence shows that the risk is about 2 in 1,000. That will be the same thing with the risk of RRD, in a patient who actually undergone cataract surgery. So for the teaching part, at least we understand, that is actually the so-called average outcome globally, or whatever that the article have actually highlighted. So when we look at patient-wide risk factors, can we look at the risk factors that actually outlined in this particular article?
This one, Prof.
Yeah.
Yeah.
So if you look at this particular article, so we can actually divide them into a demographic first. For example, if you have a patient with the high myop,
Mm.
do they define the high myop already?
Hi Mayo, this study they took the apa ni the SLM more than 26 millimeter, Prof.
Okay, okay.
Mhm.
So that is important for I think for us, if let's say we those who actually practicing the lens exchange, meaning that patient are 6'6" with glasses, and then we offer cataract surgery. So high myop is actually there is actually a high risk factor. According to this high risk factor is higher 1.5 already. Kalau high myop.
Sorry, Prof.
The risk
Oh
factor
yeah, sorry. Okay. Um,
untuk the high myop, okay.
okay.
1.2.
Okay, when they compare, okay, this the risk factor that they analyze. Okay, the lattice both had increased risk based on the regression analysis, but the highest odds ratio would be if presence of the lattice degeneration. But we understand that in case of high myopia, usually they also had together with the lattice kan. So kalau if they had macam combine risk factor tu, I believe dia punya risk akan jadi even more higher. Walaupun dia tak buat combine risk factor.
Okay. Okay. So meaning that if you to begin with your high myop and you already have PVD.
PVD ni they said that in this review, okay, the PVD that found out after post-operative.
Okay.
Okay, kalau in case of the risk factor of PVD ni kan, okay, from the previous literature mentioned in this analysis, dia macam a bit contradict dengan previous literature because
Correct.
previous literature found that patient with PVD they has lesser risk of the
Correct.
RD or test. But this study they found that a bit, a slightly increased rate to develop RD as well as the RD. So that's why even though they macam contradict to the previous literature, they still suggest in patient that we found the PVD post cataract surgery. Also, we need to be careful because that PVD may be precursor for the test and RD. Just to be careful, the recommendation.
But
from this paper.
that is correct in terms of our understanding, where the PVD, and not to say they are contradict, but it depends on, again, the progression of that PVD. There's some people say that if you don't have a PVD, then there's a risk that PVD will happen, and
Mm,
that will induce tear. And actually, there's a certain paradigm saying that if you have PVD, so you might have more PVD, in terms of the detachment on different area.
mm,
It could be to the peripheral. So that's why the PVD concept sometimes a bit confusing. And this is talking on the refractive side as well, because
mm,
whether you want to do suction or not suction. So it used to be PVD was one of the main criteria.
mm,
So they say that if, let's say, you have a PVD, then the suction is better because you already detach, you don't induce. But then people said no, with people who are PVD, then you might actually have tear. I think the discrepancy in terms of that PVD is because of, I think, the progression of that PVD itself, the nature of PVD. But
mm,
this is important because meaning that if the patient have the weakening or signs of weakening, let's say lattice degeneration is as if like when you look at there is actually a white without pressure, all that kind of weakening of the retina, especially periphery, they do actually have a high risk of developing RRD. Can
RD. The Prof. Prof,
Yeah.
one more thing I want to highlight to everyone lah, because our center is the reference center for the VR, for the intersegment cornea semua kan.
Mm.
So we always macam buat repeated procedure, repeated surgery for our patients. Okay, so I think we also really need to consult patient about risk of RD test semua lah. Because of repeated procedures, ocular procedures pun dia akan, I think dia high risk for this thing as well. So we need to counsel the patient. Sometimes bila things happen, patient macam dia punya tone tu macam nak kata, yelah dia faham maksud saya kan? Macam bila
Faham,
jadi
faham,
tu,
faham.
dia
Yeah.
akan kata macam mungkin our operation akan menyebabkan, it's actually the risk to develop this RD and test dia akan increase lah with the repeated ocular
I think that
procedures.
is a very, very good point.
Mm,
A very good point. Any reconstruction work anteriorly, either repeated PK or anything that we do anteriorly, there's a risk posteriorly, and that noted. We have at least now, when we see one patient develop RD post PK, and the other patient actually query inferior RD. So we have seen that, and then I think that is a correct point. Thank you so much, Hadi. Thank you
yeah,
so
Prof.
much, Kamal. Yeah,
Thank
thank
you
you
for
for the
your feedback, Prof.
presentation. So we will actually proceed to the departmental meeting daily to see. And thank you all.